This is boring, but it's about to destroy a few things you believe about Sjogren disease. Not the disease itself. The beliefs surrounding it. The ones you've probably repeated to a friend, a co-worker, or even yourself, without ever questioning where they came from. You refill your water bottle for the third time before noon. You carry gum, lozenges, eye drops, a small survival kit tucked into every bag you own, packed the way other people pack a phone charger, automatic and unremarkable. Somewhere between the second refill and the third piece of gum, you stopped noticing you were doing it. And somewhere along the way, you started believing this is a small disease. A dry, uncomfortable, but ultimately minor condition. The kind of thing you manage quietly and never really discuss, because it doesn't sound serious enough to bring up. Here's the problem with that belief. It isn't just wrong. It's the reason so many symptoms outside your eyes and mouth never make it into the conversation at all. If dryness is the whole story in your mind, then the joint stiffness, the fog, the burning feet, the exhaustion that sleep doesn't touch, start to feel like separate, unrelated complaints instead of parts of the same pattern. Today, that belief, and 7 others like it, are going to be tested against the actual research, one at a time. By the end, you'll know which of these beliefs are true, which are dangerously incomplete, and one that most patients never hear stated plainly, even by their own doctors. Around a third of the way through, we're going to look at a test result that can say normal while something in your body is still very wrong, and what that gap actually means. This video is meant to help you recognize patterns and prepare better questions for your medical team. It's not meant to diagnose you, and it won't replace your doctor. Hit subscribe and leave a like. That helps this channel reach more people who need it. The goal at Health Inside is 200,000 subscribers. Please subscribe so the algorithm doesn't leave me stranded. And if you want the full Sjogren symptom map guide with visuals, symptom breakdowns, and additional resources, type symptom map in the comments, and I'll send you the link to access it. Belief 1. Sjogren is just dry eyes and dry mouth. Picture the last time you tried to describe your symptoms to a new doctor. They asked about your eyes. They asked about your mouth. Maybe they checked a box, handed you a pamphlet about artificial tears, and moved on to the next patient. You left with a prescription for eye drops and a quiet feeling that something bigger went unsaid. That exchange reflects a real and common misunderstanding, not just an impatient appointment. Research following nearly 1,000 Sjogren patients found that 70 to 80% showed at least one systemic feature, meaning something beyond the eyes and mouth, at the very moment they were diagnosed. Joint pain, skin changes, lung symptoms, nerve involvement. That's not a rare subset of unusually severe cases. That's most patients, most of the time, from the very first visit. Sjogren is what's called a systemic autoimmune disease, which means the immune system doesn't stop at the glands that make tears and saliva. It can reach joints, skin, lungs, nerves, and other organs, because the same underlying immune process runs through more than one tissue at once. Dryness is simply the part of the disease that's easiest to see and easiest to treat with a bottle from the pharmacy. The parts that are harder to see are just as real, even though nobody hands you a pamphlet for them. If you've been told your treatment is done once dryness is managed, that's worth revisiting, because managing the visible symptom doesn't mean the underlying disease has stopped moving. The responsible action here is simple. The next time you're asked about your Sjogren symptoms, mention what's happening beyond dryness too, even briefly, even if it feels unrelated. Joint stiffness, skin changes, breathing changes, all belong in that conversation, not as a separate complaint but as part of the same disease. Belief 2. If you don't have dry eyes or a dry mouth, it can't be Sjogren. This one surprises almost everyone, including some clinicians. Research reviewing sicker symptoms in confirmed Sjogren patients found that roughly 1 in 5 never develop dry eyes or dry mouth at all. Some are diagnosed years later, after a completely different symptom brought them into a doctor's office. Consider a composite example, built from a documented pattern rather than any single real patient. A woman develops sudden weakness on one side of her face. No dryness at all, nothing that would make anyone think autoimmune. She's evaluated for a neurological cause, and it's only after extensive testing that antibody patterns consistent with Sjogren are found, with no sicker symptoms present anywhere in her history. Case reports describing this exact pattern exist in the medical literature. This kind of presentation is uncommon, but it illustrates something important. The textbook symptom is common, not required. If your body has been sending signals that don't fit the dry eyes dry mouth mold, that doesn't rule anything out on its own. If this belief has ever made you second guess your own symptoms, or made a doctor dismiss a concern because you don't seem dry enough, you're allowed to push back on that logic specifically. If a pattern like this sounds like it's touched your own experience, even in a smaller way, you can type "still real" in the comments. Because the next belief explains why even a completely normal test result doesn't always mean nothing is happening. Belief 3. A normal nerve test rules out nerve damage. This is the belief most worth pausing on, because so many patients have been told exactly this, word for word. Picture standing up from the couch and feeling the room tilt, just for a second. Picture your feet burning at night, for no reason you can identify. You mention it, a nerve conduction study is ordered, and it comes back normal. From that point forward, the symptom often gets quietly reclassified as anxiety, restless legs, or simply nothing worth pursuing. Here's what that normal result actually means, and what it doesn't. Standard nerve conduction studies are built to detect damage in large nerve fibers. They are not built to detect damage in small nerve fibers, the ones responsible for pain, temperature sensation, and automatic body functions like heart rate and sweating. Sjogren disease can damage exactly those small fibers, in a pattern researchers call small fiber neuropathy. A skin biopsy, a small sample of skin examined under a microscope, can detect reduced or abnormal small fiber density even when the nerve conduction study looks completely normal. In other words, the test wasn't wrong. It simply wasn't designed to look at the part of your nervous system that's affected. And here's the connection that rarely gets explained clearly. One study found that patients with this type of small fiber damage were roughly 8 times more likely to also experience dysautonomia, meaning dysfunction of the automatic nervous system, compared to patients with large fiber nerve damage alone. That's the link between burning feet and standing up dizziness. They are not two separate mysteries. They may be one shared nerve problem, hiding behind a test that was never designed to catch it. If this pattern sounds like yours, the responsible next step is specific. Ask directly whether a skin biopsy for small fiber neuropathy, separate from your prior nerve conduction study, would be appropriate. A normal result on one type of test is reassuring information. It is not complete information. Belief 4. Fatigue and brain fog are just stress, or just getting older. Think about the moment you're mid-sentence, reaching for a word that used to come easily, and it simply isn't there. Or you reread the same paragraph 3 times and still can't hold on to it. Research reviewing cognitive symptoms in Sjogren patients found that brain fog and mild cognitive difficulty were reported by roughly 40 to 80% of patients, depending on how researchers measured it. A more recent review found that reduced quality of life in Sjogren disease tracked more closely with fatigue and emotional burden than with the standard blood tests used to measure disease activity. That means your labs can look stable while your daily experience does not. This is not proof that stress or age play no role at all. It's proof that they are not the only explanation, and treating them as the only explanation can leave a real, measurable pattern unaddressed. There's a second piece worth knowing. Thyroid disease overlaps with Sjogren more often than almost any other condition, in roughly 1 in 5 patients, and a mild, subclinical form can exist without obvious textbook symptoms like weight change or visible swelling. An undertreated thyroid problem can deepen fatigue and fog that already feels like just Sjogren. The action here costs you almost nothing. Track when your fog is worse, whether it follows poor sleep or a symptom flare, and ask specifically whether your thyroid antibodies, not just your basic thyroid levels, have ever been checked. Belief 5. If I had a second autoimmune disease, my doctor would have caught it by now. This belief feels reasonable, which is exactly why it's worth challenging. Picture being on a steady treatment plan for rheumatoid arthritis. Your medication gets adjusted. Your labs improve slightly. But your joint still feels swollen, your mornings are still stiff for hours, and the improvement never quite arrives the way it's supposed to. Research using a large patient registry found that roughly 3 in 10 people with rheumatoid arthritis also meet criteria for Sjogren disease, a number that climbs the longer someone has lived with RA. A separate real-world study found that patients with both conditions were meaningfully less likely to reach remission than RA patients without Sjogren, with the probability of reaching low disease activity dropping by somewhere between roughly a fifth and a third, depending on how remission was measured. That gap is not a small statistical footnote. It can be the entire difference between your treatment failed and a second disease is quietly working against the first one's response. A separate 2024 study looked specifically at Sjogren overlapping with lupus and found that the combination behaves like its own distinct clinical pattern, not simply lupus with a bit of extra dryness added on. Two autoimmune diseases sharing one body don't add their symptoms together in a simple line. They interact, and that interaction can look like a treatment that just won't work. If your treatment has plateaued, mentioning dryness, fatigue, or joint symptoms that feel separate from your main diagnosis is a specific, reasonable thing to raise, not an accusation that anyone missed something. Health Insight exists to connect research like this across specialties your appointments usually keep separate. So let's go straight into the belief that explains why so many of these patterns take years to name. Belief 6. Diagnosis happens fairly quickly once you bring your symptoms up. A population-based study following nearly 2,000 Sjogren patients found the median delay between the first appearance of dry eye or dry mouth symptoms and formal diagnosis was close to 2 years, with patients averaging multiple outpatient visits along the way. And that number reflects patients whose dryness was recognized as a clue at all. For the roughly 1 in 5 without dryness, or for those whose first symptom was neurological, joint-based, or purely about fatigue, the delay is often longer and far less studied. Picture that timeline lived in real time. 2 years of appointments. 2 years of being told it's probably nothing, probably stress, probably normal aging. That length of delay isn't proof that your case is mild. It's closer to proof that the checklist most doctors are working from is incomplete, built around the most visible symptom rather than the full pattern. The action here is small but powerful. Write out a simple timeline of your symptoms, in the order they started, before your next appointment. A written pattern is harder to dismiss than a list of complaints delivered one at a time across separate visits. That delay matters most for the belief we haven't touched yet, the one that tends to sit quietly underneath all the others. Belief 7. Sjogren is a mild disease that doesn't affect how long you live. This is the belief that deserves the most care, because it's easy to get wrong in both directions. Being told, at least it's not serious, can feel dismissive when you're the one living with it every day. At the same time, this is not a video meant to make every viewer believe she's facing a life-threatening illness, because for most patients, that simply isn't the pattern the research shows. Here's what the evidence actually supports. A large multi-year registry study found that mortality risk in Sjogren disease is not spread evenly across every patient. It concentrates in a specific, identifiable subgroup, patients with certain antibodies called cryoglobulins, and patients with high systemic disease activity at the time of diagnosis, each roughly doubling the risk of death compared with patients who don't have those markers. Separately, Sjogren disease carries an increased risk of non-Hodgkin lymphoma, a type of blood cancer, occurring in roughly 3 to 10% of patients across different studies, several times higher than the general population, but still representing a minority outcome, not an expected one. Warning signs researchers associate with this risk include persistent salivary gland swelling, swollen lymph nodes, and certain blood markers your rheumatologist can track over time. None of this means every fatigue flare is a warning sign, and none of it means you should assume the worst about your own case. What it does mean is that mild is the wrong word for the disease as a whole, even though many individual patients do have a stable, manageable course for years. The responsible action is not fear. It's information. Ask whether your systemic activity has ever been formally scored, and whether cryoglobulin testing has ever been part of your blood work. Those 2 data points are part of how modern care identifies who needs closer monitoring and who doesn't. Here's the turn, because everything you just heard is more useful now than it would have been 10 years ago. Risk stratification tools like systemic activity scoring didn't always exist in their current form. Today, they let your care team separate the majority of patients with a stable course from the smaller subgroup who benefit from closer monitoring, instead of treating every patient the same way by default. Recognition doesn't erase the disease, and nothing here promises a cure or guarantees a particular outcome for you personally. But recognition does change what happens next. It changes whether your care team is watching the full pattern or only the part that's easiest to see. It changes whether a plateaued treatment gets questioned or accepted as the ceiling. It changes whether a normal nerve test closes a conversation or opens a more specific one. Here's your scorecard, boiled down to what actually matters, and stick with me, because the details in here are the ones people usually find out too late. Sjogren's is systemic, not just glandular. It's easy to file this disease under dry eyes, dry mouth, and move on. That's the mistake. Sjogren's can involve the joints, the lungs, the kidneys, the nervous system, and more. So symptoms beyond dryness deserve to be named out loud in every single appointment, not mentioned in passing or left out because they seem unrelated. If something feels off in your body and you're not sure it counts, say it anyway. Let your doctor decide what's relevant. That's their job, not yours. The dryness myth trips up more people than you'd think. Roughly 1 in 5 patients never develop dryness at all. Read that again. That means the absence of dry eyes or a dry mouth doesn't rule anything out. If you've been told you don't have the classic symptoms, so it's probably not Sjogren's, that reasoning has a hole in it big enough to delay a diagnosis for years. Nerve symptoms deserve their own conversation. A normal nerve conduction study does not rule out small fiber neuropathy. The two measure different things, and standard testing can miss small fiber involvement entirely. So if you're dealing with burning feet paired with dizziness when you stand up, that combination is a specific, recognizable pattern. It's not just getting older or being out of shape. It's worth naming directly, by name, in the room with your doctor. Brain fog and fatigue are real, not a character flaw. These are measurable, researched experiences, not simply stress, not simply age, not something you should be pushing through with more coffee and willpower. At the same time, thyroid testing is a low-effort, low-cost way to rule out one compounding cause that can mimic or worsen these exact symptoms. It's a 5-minute blood draw that can save you months of guessing. A plateau in treatment is information, not failure. If your treatment has stalled, you're doing everything right and still not improving. That plateau is worth mentioning alongside any dryness or fatigue you're experiencing. Why? Because a second overlapping autoimmune disease is common enough in Sjogren's patients that it should be asked about directly, not stumbled onto by accident 2 years later. Diagnostic delay is not a verdict on how serious your case is. If it took years to get diagnosed, that's common, and it says far more about incomplete checklists and narrow diagnostic criteria than it does about you or the severity of your disease. Don't let a slow diagnosis convince you that your symptoms were ever not that bad. They were real the whole time. The scary statistics need context, not panic. Mortality and lymphoma risk in Sjogren's are real, but they are concentrated in an identifiable subgroup of patients, not spread evenly across everyone with the diagnosis. That's exactly why asking your doctor about systemic scoring and cryoglobulin testing matters so much more than sitting at home guessing from search results. Get the actual numbers for your actual case instead of borrowing anxiety from worst-case statistics that may not apply to you. Now, separate from everything else in this video, here's what needs urgent attention. These are established emergency warning signs, full stop. Sudden severe weakness on one side of the body, slurred speech, sudden vision loss, fainting, chest pain, or severe difficulty breathing. These symptoms need immediate emergency care, not a scheduled appointment, not a let's wait and see, not a message to your rheumatologist portal. This is true whether or not they turn out to be connected to Sjogren's at all. When in doubt, treat it as an emergency. And finally, what we still don't know. Researchers are still refining exactly how cognitive symptoms, small fiber neuropathy, and systemic risk interact in any one individual. This isn't settled science with all the edges filled in. It's an active, evolving field. That's not a weakness in the research. It's a reason to stay engaged, ask your doctors what's new, and advocate for yourself as understanding continues to grow. If this scorecard gave you language you didn't have before, that's the whole point. Walk into your next appointment and use it. If this video finally put language to something you felt for years without a name for it, that was the point. The belief that boring and small go together is the one belief this entire video was built to take apart. And there's one more belief we haven't tested yet, the one that assumes if this were serious, you'd already know exactly what to watch for. That's where we're going next.